Yeah, welcome. Pleasure to be here with you. I'd like to kick off today on a topic that I don't think has been covered thus far, but it's coming on your radar. And that is about two elements of precision health, precision medicine, the application of that, and how it applies with cardiovascular, but more so in the wider spectrum of diabetes and cardiovascular and renal. This is the flight plan today, so just to take you through, I don't want to make it into a lecture, rather than have to take questions as we go through. The plan is to introduce to you this term of precision medicine to health, what are the differences, how precision health is already helping and where we see the future of that. This idea of cardiovascular kidney metabolism syndrome and that general continuum that we have, and where we're looking at precision health within cardiology itself. Quick sort of introduction here, and I think people have heard the term precision medicine. It's also been called personalized medicine. And if you strip away all of the razzmatazz, what it's really trying to do is to improve and better target therapies and outcomes for our patients and to better risk stratify. That term, which I think we all emulate to but have difficulty in an NHS setting. It uses a number of variables. It uses some of the high-tech, high-life science elements of genomics, appreciates where we are in terms of the environmental components known as epigenetics, lifestyle and interactive points within population health. And it uses those big terms of big data. It's so big that we couldn't come up with another term except bigger. And so that bigger data and those sort of mathematical inputs, we'll give some examples, and we'll also touch upon this element of AI, which I will sort of hopefully talk to you about, where it's nothing really more than mathematics. And we're trying to put all of that together and apply it in different entities of what we call multi-omics, entities of genomics in different guises. And all of this is to better understand disease pathology, because in the end, it's with that that we have better therapies and outcomes. So, if we went back 100 years ago, this is in 1925 what the spectrum of healthcare was like. And if you look back, we're doing the same thing to what was done by our predecessors. In 1925, the average age in the United Kingdom was 58 years old. And by that stage, such was the excitement on survival from a lot of diseases that had come from the 1700s and the 1600s, that people were saying, well, by 2025, which we are now, maybe people will survive till 1,000 years. And this whole idea of longevity has been around for a while. And interestingly, that whole point, going back from Shakespearean era and lifespan, really goes back to this point about how healthcare and our understanding of health and disease permeates from that. Hands up, anyone knows who this person is? Anyone? He's got a very nice moustache. He's not the person off the Pringle advert, I'll tell you, but this is actually the Nobel laureate, William Einthoven, who discovered the EKG, electrocardiogram, back in 1921. Now, what's interesting about this is that, generally speaking, from that point, we have come a long way. I want to just look at this and just say, pre-Great Depression, 1939, going prior to the Second World War, the literacy rate, global literacy has skyrocketed. Okay? In that era, in the area of the Great Gatsbys, that was a very elitist, aristocratic background where people couldn't read and write well. In fact, the numbers were looking at 5 to 6% of general population. Now, if you're not hitting 86, 87, even going to the aspects of 92%, that is the general global norm. Poverty, go back again. extreme poverty, from the United States to the UK, poverty, we have done amazing work as a collective, as a global community, to bring that down. And that's still now going down at a steady rate. It's currently hovering around about 8%, but still in the right trajectory. And all the while, this is going up. It's a reflection of all of these attributes, and I think as a result, world health and the general population has been increasing. But we pay for all this. And if you look at this is data from the World Bank, this year, global life expectancy has, as you quite rightly saw, previously been going up. The blip here is the COVID-19 pandemic. We are still not back up to that earlier trajectory, but we are getting there. But it shows over the last 60 years, the trajectory has been an increase. Obviously, there are variations in different parts of the world, but as a whole, collectively, we have come a long way. But the mortality point here is interesting, that prior to COVID, the general synopsis is more and more people globally are having mortality due to non-communicable diseases. And that is a reflection of where we are as a society. My mother once said, you pay for what you get, right? And we are spending a lot. An expenditure going back to the NHS, 317 billion back in 2024. We are still hitting that, and it's rising at about 6.5% annually as a result. This graph is interesting. We use these sort of economic graphs, nominal or real. It's a really confusing economic term, which is saying, does it include inflation or not? If you take the inflationary powers of what fiscal spending has been like, we have still seen a 2% rise in NHS. What does that actually mean? In real terms, we are spending more than we ever did. But interestingly, when you get down into the detail, and I'm afraid it's always down to the detail here, is the decrease in spending in preventative care, which has decreased almost by greater than a third since 2022, has shown that actually we may be spending more, but are we spending wisely? And I think this is where elements of precision health, precision medicine are here in that point, because we talk head on about numbers, population, biological, financial, fiscal numbers. But why do we ask the people what really matter, our patients? And the patients have always spoken. Going back to this seminal piece of work by Coulter et al. For the King Fund back in 2011, we know what patients want. It doesn't change. They always want, and quite rightly so, should demand higher standards of care, more information and input about their treatment, and more involvement, more encompassing their beliefs, outputs, and being part of that journey in care. And with that, there's that caveat of saying, we want the biggest and best, but we have to pay for that. Now, it's interesting that this conference is rebranding, as I learned, to not just diabetic preferential care, to CBRM, makes a lot of sense. It makes a lot of sense because we have some shared collective problems. From a cardiovascular sense, we have a number of patients, 7.8 now million patients living with cardiovascular disease in the United Kingdom. An annual cost of about 12 billion to the UK economy. Within that, we have in the spectrum of diabetes, if you look through, we have almost 1 million undiagnosed, and this number is set to rise to 5.8 million by 2030 as a whole. But in your general general medical take, 1/4 of all UK input patients coming in are coming because of cardiovascular disease. So it makes sense, does it not, to not live in silos of speciality, but rather look at this as a collective, as a spectrum, because the biology and underlying pathophysiology of this is not in a unified, singular way. We know that from our time in medical school, from our clinical training, from our understanding of basic physiology. And that linkage is important. We know, for example, this benign condition of atrial fibrillation, which we've come to take for granted, is so benign that 50% of patients don't even know they have it. They know, however, that they are 5 times more likely to have stroke after being diagnosed with atrial fibrillation, and it is one of the major contributing factors within diabetes. What's intriguing about this is that if you know that almost 3 to 5 times more likely for a diabetic patient to come in because of a cardiovascular hospital condition, what are we doing about it? And how are we going to tackle this as the numbers increase? And we know well over a third of diabetic patients are suffering from diabetes, not just on its own, but because of the cardiovascular disease outcome that they're really trying to get under control. So, this is where I'd like to talk a bit more about this unifying concept of CKM, cardiovascular kidney metabolic syndrome. It's a spectrum, it's a continuum throughout. It was defined back in 2023 by the American Heart Association, and it really tries to understand the basic science physiology, which looks at the inflammatory and the suddenly oxidative stress inputs of adipose, fat, insulin resistant, and how that impinges right across, not just from individual components of vasculature, but actually going back to the heart, and where it contributes to scar and fibrosis delineation. That process has been defined in the 4 stages of CKM, and if you look from where we are from stage 0 to stage 4, you get pretty much the whole plethora of cardiovascular outcomes. Why? This is really where it's very damaging. You have a lot of scope up here, but very little maneuverability here. And therefore, how can we impinge on this stage has been a key focus of our work and the general focus of precision health as a whole. Now, that mechanistic core, I want to go back to, just spend a bit of time on that, because I don't think we spend enough time. We talk about these things, but we don't really go back to the underlying first principle. And the underlying first principle is that input is that inflamed adipose tissue is almost like an endocrine organ. It's an endocrine organ that is poisoning every vascular bed. And one of the key vascular beds, as you know, is the cardiovascular system. And that is why when we look at this, when you look at the pathophysiology of this, your renin-angiotensin system, hypertensive, activates the sinoatrial node activation within the heart, which links up to the early endocardial epicardial arrhythmogenesis, which then impinges on kidney function as well. And that remodels the entirety of the atria in the heart, causing that to be a nidus for arrhythmogenesis. Short answer is, they are all interconnected. And the way we phenotype, we look at it clinically, has been to see things in a unidimensional way, but the biology doesn't think unidimensional. The biology is all-encompassing, and we are catching up with the clinical outputs of what we have been trying to manage for a number of years. And go back to this point about atrial fibrillation, because I believe that atrial fibrillation, in the way we think about it, is not incidental. It's not incidental if you go back to the mechanistic core, it's not incidental, it's a predefined program which is occurring given the background biology that I've told you about. And therefore, it is an indicator of a metabolic arrhythmia. And hence, that's why the two are so well meshed in diabetes and cardiovascular, where we know the worsening renal perfusion and metabolic control leads on not to an end goal, but really to an end terminus of having cardiovascular perfusion to be limited. All of this, in terms of diabetes as a headline, leads on to cardiovascular outputs directly. And we have sufficient evidence to show that what we're really showing is that substrate of atrial fibrillation as a clinical phenotype. Yet let me ask you this question. How is it, therefore, that we're still reliant on a time-based diagnosis for a biology that has no negation of time? You ask people to look for atrial fibrillation in 24 hours, you don't find it. Then you go 48. Then you say, okay, try again, 72 hours. Then you say, give me 7 days, 14 days. Why are we not understanding that the biology should be in the power of the patient? Why are we not looking at that anytime, any place, anywhere? Because if you're serious about finding these clues, they exist already. It's just that our current phenotyping systems are not up to scratch. Busy slide, I'm sorry, but it's just to show you, don't take my word for it, we have a lot of evidence for this, to understand why earlier diagnostics to catch atrial fibrillation in diabetes is important. Very interesting, I'll urge you to have a look at it if you can. The MSTOPS trial in 2023, which looked at a very simple thing. What do you do to put a wearable on patients to try and find AF? What happens? Well, what tends to happen that you tend to find almost by a five-fold, medium 100 to 530 day difference of detecting atrial fibrillation just by simple wearable. Not medical grade, just simple wearable. So the critical input for that is the instigation for stroke prevention, which we all know, and you use the CHADS-VAS score for that. And the CHADS-VAS 2 scoring allows us to keep the protective element of prevention of stroke. But it shouldn't stop there. It shouldn't stop there, and hence that's what us and other groups have been working on for a while, where we know that as part of the EAST-AF-NET program, which is another great study which looked at what is the point of intervening in this continuum. What's the point of this? And it turns out early rhythm control, not rate control, rhythm control not only reduces stroke and CV death down the line, it actually has patient outcome benefits. Because at the moment, if you look for rates and rhythm, we have always classed it as rate. And that's because we gave up. And what we're now finding out is, if you do this properly, then rhythm management should be our primary goal. And that is what patients are asking for. No one wants to be on long-term anticoagulation. No one wants to be on the drug and tablets. Therefore, it is our role to get to the bottom of the problem. Let the technology get us. Quick run through all of that. Like I said, all of this is essentially what we know to be precision medicine, an interdisciplinary term which brings genomics, clinical teams, and mechanism, risk stratification, and application of novel therapies, that use of therapeutic intervention in the future, and AI. And let me tell you about AI briefly, I'm sure you'll come across it. Those two vowels, AI, mean nothing to us in healthcare, except two outcomes. Absolutely incredible or absolutely idiotic. And the idiotic part happens when you do not involve us, the clinical outcomes. Remember, the tech does not drive the health. The health should drive the tech. But who is in charge of the tech, where is the patient? And therefore, I'd like you to consider transitioning from medicine, not everything needs a drug, to using precision health, because the methodologies that individuals can do on their own to protect and empower as patients is much more powerful than we give credit. And I think this is a point where, as allied health professionals, we in general undermine the patient when we shouldn't. People are crying out for that. It's a broader term than medicine. It approaches the whole sector of clinical consultation not to be confined to our clinical hubs, going outside into the community. And if we're serious about that, this is the way to go forward. It looks at prevention, and more importantly, this term, which I think we've forgotten, of promoting health. So, it takes away, therefore, our traditional risk models, static inputs, and we have this multi-source, multi-monitoring source of inputs and variables where the patient is in control. We are part of that journey. We shouldn't dictate that journey. We should aid that journey. And I think as part of that, integrating technology, more biologics, and this mathematical input, artificial intelligence, machine learning, is a point to consider. And give briefly to you some of the things that we're already doing, where we're using these particular gene markers, such as atrial fibrillation. We know some of the higher risk points, coronary artery disease, in particular in Southeast Asia, how we are using digital phenotypes, and I've shown it here with the Cambridge hardware heart-sense device, which is actually looking at subclinical output. What does that mean? Up until this time, you are doing non-continuous, non-applicable to patient because they don't even have the data, digital EKGs and ECGs, which you're not giving a report fast enough. You can't do it fast enough. And that's what I want to get to here, is that what are you waiting for? The technology gives you the data in 0.2 millisecond, the machine learning is faster than us. We just need to get it improved in a stratified way. When we're all using high sensitive intracranial and BMP and we're going to imaging, in terms of expense, we should be doing the simpler things, the cheaper things, faster, and allowing patients to go in. We can integrate all of that. And the power of the digital inputs that we're conferring and we're seeing here is immense, because what it means now is we can better stratify, we can model and extrapolate that out for different subsections of communities, patient profiles that we never had before. Never had before, right? I want to give you a very simple example. Just take women's cardiovascular. How long have we waited to just get some longitudinal data on what is the cardiovascular risk for women pre-menopause? Show me that data. Doesn't exist. Doesn't exist. We're very good at it, but now we have that ability to say what is happening to young women. What is that risk? What is the definable risk? What is the quantifiable risk? And how can we define it at a subclinical level? And this is the problem. This is almost asking to use Sputnik level technology, yet you want to take people to Mars. The halter is a default that you all subscribe to, all provide to, and you expect an answer, but it is not working. The system cannot cope. Your average waiting time is 6.5 to 7 months in some areas even higher. You're waiting on an expensive tech which requires the amounts of almost high-level inputs which we've done in tertiary care as opposed to out. And it requires domain expertise that you want to remain and everyone else to say, sign it off, who's going to pay for it? And it's difficult to upload and make it, and it doesn't allow for the whole maintenance of it. But my initial point is, who has that data? GP will refer it on, and then they will say, can you get a referral? Can cardiology have a look at it? Why doesn't the patient have the data? Where are they in this? The whole process is dictated by tech, not through the biology. And what we're trying to do is what we've done here. We've done this on the Chief 1 trial, interestingly, not done in the Golden Triangle, and I hasten to add. We've done it in Cambridge, but we took it out of there to understand what do you get if you apply digital EKG in real time, how fast and how quickly can we impinge on AS detection, and how can we actually use that in a stratified way. We're using not just digital ECG, but also having some other clinical variables. So this is what we're actually producing. One of the few from research, a UKCA approved, developed in Cambridge, made in the UK. It is one of the high IP companies coming out of the tech area in Cambridge. We have well over 60 patents in general machine learning. You've never heard of this, but the engineering means that for the first time, women are wearable, having a wearable without the leads. You know, if you look at the trial data, elderly people are saying, I can't go to the loo wearing a halter. How do I move away from that? These are real world problems that we could have solved, and we have solved. And that point here is to give that empowerment to patients, because when that comes to your door, that report means something, because it's a medical grade ECG output report. And that, for the first time, is done as a wirelessly charged portable device, straight to phone. Patient has the data, physician has the data, and everyone else who wants to have the data can have it, but it is in the control of the patient. I think it's the common sense choice, because if you're serious about precision health, if you're serious about where technology and risk stratification is going, why didn't you let the patients empower themselves? And I think it's time, when we're really looking for a view as part of the 10-year NHS plan, to actually show some tangible outcomes. We're talking about community care. How are we going to do it? There is a lack of infrastructure funding, for fiscal funding from that. The tech will take that to its side. The tech will do that because for the first time, what will happen when patients now come to you with a medical grade ECG? What are we going to do? In primary care, in tertiary care, what are we going to do? And that input of having that sort of data means that we need to work in unison. We can't have this divide of primary and tertiary care. We need to work in unison, because all of this is about patients. We're doing it in a way where we can have all together an input together where we can see, and all of that as an input, we can see that working in a unified, real-time diagnostic way. We have systems where we have the whole diagnostic, the PDF, which is manually done. I still see in hospitals people are printing out 24 halters and manually looking at this. Makes no sense. Not only are you cutting down trees, it's not even accessible. So we need to move away from that method and move into a way where everyone can work together on this. We need to have a system where we have the ability, and we do. We have shown this, that you can have live view ECG anywhere in the world with simple mobile output. We've even done it in 35,000 feet. It actually works, and we've already worked with the International Space Station. How do you get astronauts to have an EKG? There isn't. So we're using that as a means to say the technology has moved much, much faster, and I'm very confident that we can move that same level of impetus back to patients, back to primary care, and back in a holistic way, which doesn't make it into a science fiction story, but rather into science fact. So, if you ask me to put a prediction of where we're going in the next 5 years, we are trying to get to the 4 Ps: predictive, preventative, personalized, and participatory medicine. I think people know the first 3, the last bit were a bit, what does that mean? That's where the patient should be central in all of our points here. And the power of AI, as I said, it's just the maths. There are a lot of clever mathematics that is able to use that as a formulaic way, but to make actual clinical outcomes. But just keep on doing what we're doing as a group here is so enthusing because we have always been collaborative. Cardiology, diabetologists, endocrinologists, nephrologists, nurses, allied health, whatever term you want to call yourself, we've always been working together for the patient. That should not change. Let us put patients at the forefront of all of this, and that's where precision health comes. So with that, I'll end there, and I'll be happy to take any questions, and I hope that has landed. Okay, thank you very much.